Hello everyone, thank you for coming in today. I hope everyone can hear me. So I'll move swiftly to the program. Thank you, Lisa, for the introduction. So our panel today will be mostly gentlemen, amazing gentlemen who have achieved a lot in life, who I also look up to. So the first person I'll introduce is Dr. Neci. He is the Executive Director of Ecumenical Pharmaceutical Network. He holds a bachelor degree with honors in the pharmaceutical sciences from the University of Kinshasa, an advanced diploma in humanitarian logistics from ISS DRC, and postgraduate certificate of management from Cumbria University. Through his leadership as the president of the Provincial Council of Pharmacists that commenced in 2016, he succeeded in influencing pharmacists, colleagues, and health authorities to get involved in the sanitation of sanitation of the pharmaceutical sector and fight against fake and substandard medicine in the eastern region of the Democratic Republic of Congo. Richard has developed a servant leadership and management skill demonstrated through his work results. Richard was born in Eastern Democratic Republic Congo and is bilingual, that is, he speaks French and English. Doc, please welcome to the stage. I think you can hear me. The mic is a little bit troublesome. So the next speaker I'll introduce is Dr. Libeya Bethwel. Dr. Libeya Bethwel is a registered pharmacist currently practicing in Kenya. He is passionate about health entrepreneurship, access to quality health services by leveraging on technology, mentoring young medical professionals on health entrepreneurship, and public education on healthy living to promote preventative medicine. He currently runs a health and leadership newsletter on LinkedIn, through which he shares insights on health entrepreneurship, health system strengthening, public health advocacy, and personal development for medical professionals. He has founded the following publications, that is the Medical Hub, Any Drug Review, and Farm Hub Consultancies. Welcome, Dr. Libeya. Finally, I will introduce the next speaker, that is Dr. Desireh, whose CV has preceded his name. So Dr. Desireh is a registered pharmacist currently living and working in Kenya. He is passionate about global health, specifically on improving access to healthcare through optimizing procurement and supply chain systems. He currently works in Supply Health, a GSI affiliate, as an associate and has had the opportunity to work in initiatives to promote access to FP, capacity building for healthcare workers, and other marketing development initiatives. Dr. Desireh is also a member of the International Pharmaceutical Federation, that is FIP, and currently serves as an early career pharmacist, serves in the early career pharmacist group as an intern under the Provisions and Partnership Program. At FIP, he has had the privilege of working on policy review and practice transformation initiatives. He is an advocate for meaningful youth engagement and supports initiatives that provide opportunities for the youth. Welcome, Dr. Desireh. Okay, welcome so much, gentlemen. You all look sharp and ready for the session. So today we'll be discussing about access to health, essential medicine, health products, and technology. So when we talk about this specific health pillar, we are focusing on ensuring that these products are accessible, affordable, safe, effective, and of the best quality that we can have. And when we look at the current healthcare public sector in Kenya, there is a problem in the supply of these products and also in the quality. Sometimes there's a standard and all of that. There are a lot of factors or problems that surround the
this particular pillar when we look at the public sector in Kenya. So from your experience in the different areas that you have worked in so far, what possible approaches do you think we can take as future healthcare workers or as current healthcare workers in trying to address this problem in the public sector?
Thank you. Good morning, everyone. I'm really happy to be part of the discussion and to be with colleagues and try to discuss around the problem of access. And I think you have mentioned two among many problems we have around access. One is affordability. You have talked about availability, but there is also the issue of quality and many others, because you can't talk about access without taking the part of affordability, but mostly the quality. Why the quality? Because I'm coming from an experience. EPN, we are supporting people who have facilities. Most of them are in rural area where they try to balance between quality and price, and they are more interested on price than quality. So if we talk about access, let us also include the issue of quality. And also about affordability, I think different ways which can really help us address the issue of quality, affordability, and let's say accessibility. I think I can take it at different levels, because the Ministry of Health is in charge of making sure the country supply system is really functioning. So there is some challenges at the national level, responsibility also at that level, but also we can talk about the responsibilities and challenges which are around the healthcare facility. So at national level, personally, I see around 4 ways to improve on the availability, and we can discuss and find is all these 4 aspects well functioning at national level. One is around the management of data, because it's very difficult to improve availability, to improve affordability, access, if there is the flow of data around medicines, around where is the availability, because from the national, talk about KEMSA, they supply district, they supply the entire country, but how is the flow of information from the top level to the health facility level? This is one, because you can see medicines are at the district level, but they are not in the facility. They are at national level, but they are not at county level. So the flow of information, supply chain information, is very important. This is one. Second, I think there is also a challenge around the capacity, the skills. You can have medicine at some point, but we need also skills to make sure people who are managing drugs, who are managing those medicines, are really able to do it, so that we can make sure drugs are available. There is also an issue of transparency, because medicines in my country say the Satan is in medicines, because it's a very good business. Very good business. You can see in many countries, even those who are not qualified to deal with medicines are running medicine business. And even healthcare workers, sometimes people who are not supposed to be dealing with medicines in the health facility, you find everyone wants to be around medicines, because this is a business. So we need policies which are addressing transparency. When the medicines are supplied from, let's say, a wholesaler, how do we ensure that the price which is coming with the invoice is the real price? which they bought them those medicines. Because whenever they add on the normal price, this will affect the end user, the patient, because you have to calculate the margin and so on around the price. So you can't talk about affordability if there is no transparency around the price in all the supply chain, from the top to the last mile level. And finally, I want just to leave the time for colleagues also. The strategy of procurement. I will talk about it, how EPN-led we are doing to really make sure this works well. Strategic procurement. Strategic procurement, we have conducted some studies around health facilities to look at the different sources. What's the level of medicines coming from the national supply system, and what's the quantity or the percentage which is coming from the private sector, but also sometimes from an unregulated market in other countries. In Kenya, we have the private, the professional, and the government sector. But in other countries, you have even the informal, the unregulated market. And we found that we need to look at this, because you'll find in some countries they are buying most of the drugs through the informal market than the regulated market. This is also the issue of quality, because you don't know the medicines which are coming from those sources are of which level of quality.
All right. Good morning. It's a good discussion, and I think my colleague has covered pretty much of the challenges that we experience as a country, and the points where we need solutions. But I'll just add a little bit to what he has said. And I look at several things. Number one, the governance aspect of it, and the role it plays to ensure that people have access to quality medicine. Now, when you look at the structure of our hospitals, and begin the public hospitals, you look at the structure of public hospitals, just walk into any primary healthcare facility, you are unlikely to find anybody who is experienced or who is trained in anything to do with pharmacy. You'll find a nurse dispensing medicine. It's not bad for us to dispense medicine, but there's a reason why a pharmaceutical technologist or a pharmacist went to school for 3 years and 5 years, respectively. So, the aspect of governance and ensuring that we have the right kind of people handling pharmaceutical products is one big step that we need to take for us to ensure that our patients receive quality medicine. The other aspect is on the legal aspect. I'll talk about the legal aspect. So, he has mentioned that pharmaceuticals has a lot of money. That is true. I remember in my first year, one of our lecturers told us that if you want to become rich, either sell guns or sell drugs. Under drugs, you can either sell drugs that are illegal or sell pharmaceuticals. So pharmacy is one of the places where there is money. And let me just give you a good picture of it. The Kenya pharmaceutical market is estimated to be $1 billion US. $1 billion US. That's the Kenya pharmaceutical market. Now, we have local manufacturers, around 40 or so companies. 35, last time I checked licensed pharmaceutical manufacturers, 35 of them. And they own around 28% of that $1 billion US. So really, more than $700 million US are drugs which are imported from abroad. India being the leading exporter to Kenya at 7%. So there's money in the pharmaceutical space. The Pharmacy and Prisons Board is the parastatal that has been mandated to govern that space, the practice of pharmacy and sale of pharmaceutical products. They are doing their best, but they haven't yet hit the mark where you say they have capped all the preference of importation of products which are not being certified as far as their quality is concerned. So out here we have people buying medicines that were imported into the country, but they haven't been certified by the board. So you find them in the pharmacies, you find them in medical facilities, primary healthcare facilities. Of course, we understand that KEMSA is there as well to supply the government facilities, and Neci is there to supply the faith-based institutions. But we have private importers who are not necessarily using the right way to bring medicines to the country. And this now puts the lives of patients in danger because medicine can be a poison. If you take a medicine the wrong way, you're likely to die or you're likely to be compromised, right? So if something is not certified as far as quality is concerned, then you're putting the life of this patient in danger, and that's what we are having. So if you have strengthening of the legal framework of regulating importation of these products, then it will be one great step towards ensuring that quality medicine get to the people. Now, allow me to quickly switch to affordability, and that is the aspect of price, and I'm glad that we talked about it as well. Early this year, I was doing a random research from the community pharmacists, or what we call chemists, and I sent out a questionnaire for them to fill. And some I did call and had a conversation. And one of the things that I was asking them was affordability line of family planning products. And I was shocked when one pharmacist told me that he encountered a patient who had come to him, and the patient had asked to buy one pill of what we call Cizungu in the other Femiplan. 1 pill of Femiplan. You know, the whole dose of Femiplan for the entire month is 7 shillings. So the patient was saying, I can't afford 7 shillings. I just want one pill. You know, I don't know if you're getting that picture. The entire dose for 1 month is 74, but he just wants one pill because they can't afford 7 shillings. So that takes the picture where a majority of Kenyans are currently, a bigger percentage of Kenyans. Many people in this country are living below $1 a day. So if you give them an option of putting food on the table or going for medication, if the disease or the condition is not that severe, they would rather eat and see another day while their stomach is full than to go and buy that medicine. So affordability is an issue. Now, how do we, what are the solutions towards it? I just share one and then pass on the mic. I'm comparing Kenya to India and Rwanda. In India, in Kenya we don't have price control. It's a free market. Pharmaceuticals is a free market. There's no price control. So if I have product A and I'm selling it in this locality, I'll mark it at a price based on the kind of population I'm serving. If it's a high end, I can sell it at 1,000 shillings. But if I take the same product to a different locality where I'm serving a low income population, I might cap it at 500 shillings. So there is no price control. Everybody sets the price the way they want. And that affects how people are getting the medication. Now, in India and Rwanda, they have what you call recommended retail price, RRP. And this RRP are indicated on the boxes, the packaging of the medicine. So when you get a medicine and you're buying it at 1,000 shillings, you will see the RRP can be around 800 or 900. And then you ask the pharmacist, why are you selling at 1,000 shillings and the RRP is 900? They have to justify that. Maybe they tell you the cost of doing business in this location is quite high, so I'm selling it at 1,000 shillings so that I'm able to remain in business. So there is justification for when one is selling a product beyond the RRP. But that is not in Kenya. In Rwanda, the same as India. They have an RRP, they have guidelines as far as price control is concerned. But in Kenya, it's not there. So one of the ways you can address affordability is through having price control of pharmaceutical products. Thank you.
Thank you. I think what is coming out very clearly from my colleagues is that it's largely a systemic issue, and there are so many players in the access field that if I was to pull up the supply chain project for just the public side, including all the players that are involved, we probably get dizzy in this room. So it's very complex, and sometimes there's a lot of finger pointing. But I think it's, as they've said, it's still important for the existing systems to be aligned both at the national and the county level. And it's some of the things that already mentioned, so better forecasting, better procurement at both the national and the county level. We've had excellent examples of the use of third-party logistics in other African nations, and it's revolutionizing the way product gets to the last mile. And I think most importantly, it's also ensuring that the commodities that get to the facility are stored properly and rationally used. I think for me, and with my experience so far, is that it's the healthcare seeking behavior of Kenyans is that when I'm sick, I go to my nearest pharmacy. And if you do a quick scan around where you live, or even in your home village, you probably you can get to a pharmacy faster than you can get to the healthcare facility. And so even as we think of solving the issue of supply of medicines and access, I think it's important for us to also focus on what we can do with the community pharmacies. They're everywhere. They offer these products at affordable prices, and they're run by young healthcare professionals like us. And so it's important that we think what ways can we involve the private pharmacies, probably think of, again, collaborating with the government to see how we can leverage this underutilized crowd. Thank you.
Okay. So you've brought out quite a lot of important points, and what is really standing out is that the problem of access to essential medicine and health products is a multifactorial, I may say, issue, because you can't take a one-way approach to at least addressing some of these issues. Now, just as Dr. Desireh has said that quite a number of times you find that the community pharmacists are led by young healthcare professionals, and also in the hospitals right now, you find most of the senior healthcare practitioners are taking up administrative roles and all of that. And right now, when you walk into the healthcare facilities, the youth are the majority of the people in there. Now, what are some of the pointers that you could give that the youth should, or the gaps that the youth should address while trying to fix the problem of access and access and affordability of these medical products?
What I can say at this point, maybe it will shock you, because we work in most of our health facilities, church facilities are located in rural area. And what you find, it's not easy to find a pharmacist at that level. All of them would like to be in big cities where they will get good salaries, and we live the way those spaces which are open, where a pharmacist can do a lot if you are really passionate with the community. And I can say, EPN, we have developed what we call the essential pharmacy practices, which are online. We give those training online. Even pharmacists can benefit from that. But we developed them because we could not find pharmacists in those areas, in those hospitals. And I can assure you, if pharmacists decide to also go and work in those health facilities in rural area, this program will no longer be necessary, because we want pharmacists to take the responsibility of drugs in health facilities. We want technologies to be there, which is not the case now. I think community pharmacies are very important, and we cannot be able to create a pharmacy in big cities because it requires a lot in terms of funding, in terms of because even the rent is very high and so on. But you can start your business in those areas. You support the community, and I think there we can have impact. And don't mind, you know, if you are doing well your job, any place you can be, even if it's in the rural area, let me assure you that this will open the door for you for the next level. But we need to start somewhere. So I think the point is good. Community pharmacies are very, very important, and I think young pharmacists should take the responsibility. But again, you should know that whenever you decide to leave the field for other professions, then they will at one point feel we don't need pharmacists. You'll come in an hospital, they say we are dealing well with medicine without pharmacists. What's the need to have a pharmacy? Because we have left the space empty for those who are not really qualified to deal with medicine. So it's good for pharmacy really to take up the responsibility. I think also another point is in the last session it was well said. Even if you are far or you are in the community, it's important to keep connections. Because if you are connected, you can be far in somewhere in the county, but if you are still connected with different health professionals, this can keep you in touch of other opportunities than waiting here, doing nothing, while there are opportunities, starting opportunities in rural area and county areas. So I would really support the idea of starting on that level for young pharmacists.
All right, thank you. That's quite good reflections. Thank you. To your question, you asked about, the health facilities you have youth and the older people seems to be taking administrative positions. I think that cuts across not only pharmacy, but also the other care cadres, the medical professionals. We have nurses, we have clinical officers, we have MOs, and we have young people stepping up into the clinical space. So how do we ensure that, I not only talk about how you as a pharmacist, because I believe we have more than, the attendance here is more than pharmacy, right? So one of the areas is ethical practice. And why am I saying this? I'm sure you've come across medreps, and I think recently there's been a legislation around that try to regulate how products are being marketed. So a medrep comes to a clinician and tells them, these are my products, so let me push them. So a clinician will prescribe based on a brand name instead of the molecule that needs to administer the treatment. So for instance, if it's paracetamol, they write a brand name. I don't want to mention companies because I'm not paying for this brief. So it's paracetamol is a molecule, right? It's an analgesic. So the clinician is meant to prescribe paracetamol, but they end up writing a brand name of a company. Why? Because a medrep has seen them and they have come with a token. Either they have bought the pizza or they have brought something good for them or a lunch. So that aspect of marketing is not ethical. It's not ethical practice. And it begins with you as a pharmacist who is there to validate that prescription. When I was working in community pharmacy, I used to pick issues with that. And if there was a initial contact written, I would call them and ask them, why have you prescribed this product? The patient cannot afford this product. There is this alternative that has the same molecule. Why did you just write paracetamol? When they come, I assess because I'm meant to serve them. And one of the areas I look when serving them is that the drug needs to be safe, needs to be efficacious, and needs to be affordable, right? So the affordability aspect, I need to assess this patient. So you're not able to afford this, but there's this alternative. So are you able to pay for this? I'm able to pay for this. I won't mention the specific drug, but there's an antibiotic that most of us took during COVID. I want to mention the name. There is a original drug that goes for 1,800, but at the end it goes for 100 shillings, right? So if a patient comes to me with a prescription, they need that particular drug, and they're not able to afford the one that has been treated, the one for 1,800, because a clinician had been seen by a medrep who gave them something that motivated them to prescribe that drug. So when the patient comes to me, how do I serve them? It's safer to write the molecule. Then when they come, I'll assess them. based on the level, the kind of product that they're able to afford, they're selling to them. So ethical practice is something really key that we as young professionals need to put in mind, even as we serve the patients, because it goes a long way in ensuring that they're able to get quality services, access quality products, without them breaking their pockets. So that is one. Two is patient education is really key as well. Patient education. I don't remember the last time I took medicine, yet I dispense. I don't remember the last time I took medicine, yet I dispense. Now, I'm really hesitant to take medicine because no one gets used to medicine, but when the situation calls for it, I'll take it. The reason is we need to educate our patients. It's not everything that, if it's a headache, try to interrogate where is it coming from. Some of the headaches they experience may not necessarily be a disease, they just need rest, and that is sufficient. But what happens when they come to my pharmacy, I have to meet targets, I have to sell, right? I have to sell, I have 5,000 targets for this day, I have 10,000 targets, so regardless of the feedback I get after interrogating them, I still prescribe something. They have to go with something. And it's unfortunate that, there's a conversation I was having, and it's unfortunate that there's some hospitals, private hospitals, that clinicians have been given targets of prescribing the drug that you prescribe in a day. So a patient will come with a minor flu, but they'll have to give an antibiotic with a painkiller. That is standard. You have to push these drugs. So, those aspects, as young people, how do we operate in such spaces? We need to ask ourselves those questions so that at the end of the day, it's not about you having a patient at the end of the month, but also your patient receiving value for their money and their health being well taken care of.
I think it's hard speaking after this because there's one wrong. But there's one thing that I think the youth are best placed to take advantage of. And I think they've spoken of accessibility, they've spoken of affordability and availability, but there's one other A that is acceptability. And for any healthcare intervention, for it to be rolled out in a way that is successful, it has to be acceptable among the people who it's meant to serve. And so I know that the youth are particularly important drivers of acceptability. Why? Because most times the youth are the early adopters. We are the ones who jump on, the new drug, the new place to eat, the new app that gets you wherever you're going. And so I think it's part of the idealism and the elasticity of youth. We are open to new adventures, and so the youth are early adopters, and it's important that we realize that we can drive access to some of these medicines through being the first ones to accept it. And so this is so important that earlier when Gladys was talking about human-centered design, and it occurred to me that it's the youth who are actually called upon to take part in this human-centered design approach, because you can't build a solution in the boardroom and take it to the market just like that. So you have to make sure the problem or the solution that you're creating for a problem matches the users on the ground. And so the youth are highly involved in that process. And so it's just one of the many ways that youth can be demand creators. And I think in that sense, the potential is limitless. And to second Dr. Libeya, I think youth can be advocates and can be educators in the community. What comes to mind is rational use of medicines. I think we can have the most efficient supply chain, but without rational use at the end, we are wasting limited resources. And so the youth can also act as advocates for rational use, ensure that antibiotic that is given to your shoshu at home completed before they go back to the hospital for another cycle another that remained at home and inpatient. It sort of completes the cycle and ensures that even as we make efficient supply chains, we are not losing all the gains we've made along the way without promoting national resilience. Thank you.
Okay, thank you so much. Maybe to have the program that Dr. Desireh is going to do, start with him in the next question. So in Kenya, and I don't know if it also extends in Africa, maybe you could confirm in DRC, faith and religion also plays a key role when we are talking about access to essential medicine, health products, and technology. Specifically, maybe just a few highlights in the maybe in the past 20 years, within the time I was born, there have been a lot of issues between the Catholic Church and contraceptives. There's also an issue between vaccines and the church. And then there's also some time back an issue between the tetanus vaccine being less and all of that. So we're seeing time and again the church plays a major role in access. And you see the church has a lot of people, and those people are the ones we're targeting to at least access these medical products. So from your experience so far, or from your views, how best can we approach the church or work with the church in being able to ensure that these essential medicines, the products, the technologies that are key or are necessary in the community can be available, or how best should we go about it? Because there is, it's a sticky environment, but then what's your opinion and how best should we approach it? Because if this continues, we'll continue clashing on the church and the religion. So what are your opinions and views on how best we should approach this?
She decided to give me the difficult one. I think when it comes to the line between the church and access to medicine, it gets a little sticky because in the past it's created a lot of conflict in that the values of the church sometimes don't align with secular values. But in a nutshell, I think the church is an important player, similar to all the other private sector players in the market. And so they identify a need and they're able to provide solutions for a target group of people who, fit within a certain characteristic. So it's I'm not completely against it. I see it as a win-win because sometimes they fill gaps that honestly the public sector cannot think that they do a good job at what they're doing, and if you're all going in the same direction, I think it's so.
What? Thank you. I've had the opportunity to work to serve people in different communities and cultures. But back in campus, I had the opportunity to travel across the country to different organizations to do medical camps. And at one point, I went to Tamariva, which is a predominantly Muslim community. At another time, I went to East Pokot, around Kapendo, where we have the clashes, and they have their own culture and how they perceive medicine. They call it Madawazawazu. So they have their own way how they perceive these things. But assessing from the experiences I've had, looking across, I think the major problem comes from lack of knowledge or lack of let me rephrase that. Lack of correct knowledge, because there's lack of knowledge and there's lack of correct knowledge. So when people don't have the correct knowledge about a vaccine, when they don't have correct knowledge about family planning, product or services, they tend to shy away from that. And it's not only church, not only Christian organizations, even in Islam, even in Muslim. Last year, I attended a training that was organized by MOH together with PSK, that was on advanced family planning. And we heard one of the members being trained was from Garissa. And from the experiences he shared, he said that there are people, they can shy from family planning because of the culture and also religion. So, but he said he's work in progress to educate them of the importance of these services, the importance of these products. So it cuts across, even within the church, potential from vaccine, some types of vaccine. And how do we come in as healthcare professionals or the youth? Currently, the internet has made it available. Anybody can access information at any given time. And I think also part of the paranoia when it comes to healthcare products and healthcare products because of the information they get. Someone goes back to read about the computer, how it affected people back in the days, and they say, this thing is new, it hasn't been tested, so if we get this injection, how sure are we not necessarily end up as a computer or something else that was catastrophic back in the days. So you as a healthcare professional or a youth who has access to the information, the correct information, you're at a vantage point to explain to them that this thing is new, yes, but there are these tests that have been done. There are these tests that have been done to confirm its safety. There are these things tests that have been done to confirm that it works and it's for your good. So you play a role of educating. You play a role of educating, and that goes a long way to making them open to receive that which is being offered as far as healthcare products or services is concerned.
Thank you for those very good points. I think really young professionals, you all belong to the different congregations, and you can influence from your congregations. Let me say the church health system in Africa represents around 40% of health care. This is a very, very huge level. In Kenya, meds supply 40% of the supply system in the country. So the church is already playing key roles. And what we have found, and this is one of the experience of EPN, what we did during COVID, there was too many different misinformations around COVID, vaccines, and so on. So we created a platform which we called Health and Faith and Science in Conversation, where we brought together healthcare professionals, including young professionals, and the other side we brought together with religious leaders, those people who are having roles and responsibilities in the congregations. And we discussed. You bring their opinion, you get their opinion, and I can tell you that this is a very good way to change behavior, to give the good information to people. Because sometimes we find we have good health professionals in the churches, we have religious leaders, and they are in two different worlds. We don't have a point where we are discussing other than faith matters. And mostly, faith leaders are the ones who are, when we are in the church, we just follow. And when he said amen, you go. You don't have to discuss the opinion. But we can create a space where we can discuss. We can talk around other topics. And I've seen in many congregations, they have youth meetings, youth discussions. Why can't we bring health matters in those meetings? This can be a space for young professionals really to bring this kind of information, discuss, get the views of those who are not from the health space, and share experience. So I think this can be one. But also another approach we took as EPN, we provide scholarship, because you cannot talk about what you have not been trained for. So we try to give scholarship so that those who are already the health space. We have nurses dealing with medicines. They want to continue doing this work. We provide scholarship so that they can also take some courses or a diploma or degree. We have even young professionals who are taking diploma and degree in pharmaceutical sciences, so that they can also be able. And one of the criteria we are using to select people who take who will be awarded the scholarship, we look on how are you influencing. Are you an influencer of your society? Are you an influencer of your community? We take it as a responsibility, as a criteria, because if you are already engaged in your community, it means if you get this level of knowledge, you will continue influencing. So if you are already a pharmacist, you are a nurse, a doctor, in any profession, I think it's good really to put your leadership, your knowledge, to open it to your community. And one of the ways, using social media, it was said here, we are able to use social media to educate. You are on Facebook, you have many followers. How do you involve them in discussions around health, access to medicines, quality of medicine? We can bring those topics in our different groups, and this will also help us connect with other people and influence the community. And finally, what we have been doing as EPN, we think, access also to, because to influence, you need also to be involved in the profession. And you can see many companies, they are not opening jobs to young professionals. If you look at those advertisements, 5 years of experience, how can a young professional really access those markets? But I think in the safe sector, it's still possible to open opportunities to young professionals. And one of the ways we think as EPN we can involve people, we are opening up the space for volunteers, because this is the one entry point. You can start as a volunteer. There is an opportunity where you can learn and start influencing in those areas. Just accept to be a volunteer. If you are waiting for a good job, start by being a volunteer, and this can open you up to new spaces, new health professionals, and you can start there. Secondly, we also, in the recruitment, for example, in the case of EPN, we are not looking of how many years you have of experience, but which passion you have around the topic, around the pharmaceutical sector, around the health sector. Because someone who is passionate, even if he is not experienced, he will learn quickly and really take it up. So these are some of the things we are doing. And if you come to EPN, you find that we have most of our staff are young professionals. And EPN was sometimes one of their first jobs. But if you look at the impact they are having around Africa in the space in which we are operating, you can just say, would we need really people who have experience of years, or we need passionate young professionals who can transform the continent? So I think this is some of the key ways to engage church leaders, to engage youth who are in church, in congregations, to be part of the influence of access to medicine.
Thank you. Michele, you also.
Just to add something to what he has said, he mentioned a point about engaging, the different congregations that you belong to. The topic of healthcare, healthcare needs to be voiced. Because you're there, go and begin it. I know of a few congregations where they have how like it? There's the general church, but now within the church there are professional groups. So you find a professional group for medics. There's a professional group for, let's say, lawyers. There's a professional group for engineers. So, I mean, those groups liaise with the pastor or the leader of that congregation, and they're given days where they can come and educate the congregation on health matters. So, as a youth in that particular congregation, you know where you belong to. Hata kama wewe ni kanisa haina shida, au wewe ni msikiti haina shida. But if you belong to any of it, to any of them, go there and begin that conversation. If there is no professional group for medics, go and begin it. And then have a conversation with the leader of that congregation, see if they can give you an opportunity to educate the congregation on health matters.
Kama wewe ni kanisa iko shida.
Maybe just one more question. I know so as we wind up, I think Dr. Richard has touched a little bit more on his part. So maybe we focus on Dr. Libeya and Dr. Desireh. So in your current workspaces as pharmacists in the different fields that you are in, how are you embracing and leveraging on youth and innovation to drive access to essential medicine within Kenya or Africa? Yeah, I don't know if I should repeat.
Repeat the question.
Okay, so as pharmacists in the different areas that you are in, right now we have, I think from this conversation we've appreciated that we need to work on different areas to at least bring access